The AI-assisted OMI NOMI paradigm represents a fundamental shift in the classification and acute management of acute coronary syndromes. It replaces the traditional millimeter-based STEMI and STEMI dichotomy with a framework focused entirely on the underlying pathophysiology, specifically the presence or absence of an acute coronary occlusion, and utilizes deep learning artificial intelligence to detect the subtle occlusions that standard criteria miss. The traditional STEMI criteria are highly specific but poorly sensitive. Angiographic data consistently shows that approximately 25 to 30% of patients classified clinically as having NSTEMI actually have an acute coronary occlusion with TIMI 0 to 2 flow and lack sufficient collateral circulation. Occlusive myocardial infarction OMI. Patients with an acute or near acute coronary occlusion requiring emergent reperfusion PCI or thrombolysis, regardless of whether their ECG meets standard ST elevation millimeter criteria. This encompasses both STEMI positive OMI and STEMI negative OMI. Non-occlusive myocardial infarction NOMI. Patients without an acute occlusion or those with sufficient collateral circulation such that they do not require emergent catheterization to salvage myocardium. When STEMI negative OMI patients are treated under the standard NSTEMI pathway, reperfusion is often delayed by 24 to 72 hours, resulting in significantly higher morbidity and nearly double the mortality compared to true NOMI cases. While experienced clinicians can recognize the subtle non-STEMI ECG signatures of an acute occlusion, these morphologies are notoriously difficult to standardize and teach broadly across rapid triage environments. Deep neural network models bridge this gap by training on hundreds of thousands of ECGs linked directly to angiographic outcomes rather than human annotated interpretations. Because the AI is optimized against the actual catheterization results, that is the ground truth, it accurately identifies complex nonlinear relationships and markers of STEMI negative OMI, including hyperacute T waves, disproportionate T wave amplitude or volume relative to QRS complex, terminal QRS distortion, the absence of both S waves and J waves in leads V2, V3, subtle reciprocal changes, specifically ST depression in lead AVL, which can be the earliest or only sign of an inferior occlusive myocardial infarction. High-risk equivalents, Deventer patterns, Aslanger's pattern, and subtle posterior occlusive myocardial infarctions. By analyzing these features simultaneously, AI-assisted triage models routinely achieve a sensitivity of roughly 90% for detecting true OMI, significantly outperforming the 60 to 70% sensitivity of standard STEMI criteria, while simultaneously reducing false positive cath lab activations.